Okay, thank you very much. Could we have the next slide, please? Well, welcome everyone, and thank you very much, Daniel, for the introduction. Today, we hope to share with you some of the work that we've found about what best practice in training for staff in non-specialist NH trusts look for people with learning disabilities actually looks like. The work was commissioned prior to COVID and obviously predates the requirements around the mandatory training around people with a learning disability that has come into force with the Health and Social Care Act 22. What we're going to be doing is talking through the various stages of our project and what we found. We'll be sharing this information with you until about 1:15, and then, as Daniel says, we're going to have breakout rooms. So there's going to be an opportunity for everybody to have a chance to discuss what you've heard, but also to share perspectives. My name is Callie Ward. I'm a member of the project team. I'm a family carer of a man with learning disabilities who's 52 and has very complex health needs. And so we have a great deal of experience in non-specialist trusts getting the right sort of healthcare for him. Okay, over to Anna and Rachel.
Thank you, Kelly. My name's Rachel Turner. I'm a self-advocate and trainee researcher, and I do lots of different work for NHS, learning disability and autism to improve people's lives.
Hi, I'm Anna Marriott, and I'm Research and Evaluation Programme Lead at the National Development Team for Inclusion, and I was project lead for this work.
Thank you. Next slide. Thank you. And very quickly, because Daniel's covered most of it, we want this to be interactive and to work for everybody. And as has already been mentioned, the opportunity for fuller discussion will happen after we shared with you the findings of our project. So I think it's over to you, Anna.
It is, thank you. So as Callie said, Callie, Rachel and I, next slide please, will be giving you a brief overview of everything we've done on this project, which has now been completed. But I should point out that there has been a wider project team involved in this, several more experts by experience, as well as other colleagues at NDTi and other associates. So it's a team effort, but we're here representing the team today. So the aim of this work was to identify good examples of training programmes for mainstream health professionals, ultimately so they know how to support people with learning disabilities better. We also looked at what people need to help them put the training into practice, because we're really aware that you need good training as a first step, but actually in order for people with learning disabilities to get better care as a result of that, which is ultimately what really matters, there are some other factors that need to be considered. So we sort of were looking a bit wider than that. Now, our remit for this work was just around learning disability awareness training, not autism. So, and this work was up and running prior to the commission of the Oliver McGowan mandatory training in learning disability and autism. So, although that's very relevant in terms of the context when we think about this training coming in because of the new change around mandatory training, just to be clear, our remit for this was looking at NHS trusts in the South region for learning disability awareness training. Next slide, please. That's just a little flowchart of the different stages of work that we've done. We'll be talking through all of those today. We originally had less stages down because we were due to do some more intensive field work, but that was due to start in March 2020 with visiting hospitals. So unsurprisingly, there was quite a lot of a pause and a rethink at that stage, but it did mean that we actually got to do some additional stages of work. Stages 5 and 6 and 8 were added in as extra bits of work. So hopefully we've got somewhere that it was a good point to reach to. Next slide, please. So the very first step of this was the literature search or the evidence search. And what we were doing here was asking the question, what's the current evidence on the effectiveness of learning disability training programmes directed at staff working in NHS trusts? We found 14 articles that related to this question very specifically, but we also looked about wider learning was relevant. So we included articles about learning disability awareness training for students or within education. But also we reviewed evaluations of things like learning disability awareness training for the police, But we also looked at other training for NHS staff like dementia awareness training. So we were trying to think as widely as possible about what we could learn from this. When we focused on the 14 primary studies, though, that were about learning disability training delivered in a healthcare setting, we were concerned that there were a number of quality issues and limitations about those. So these concerns included things like small sample size, no control groups, but also there was very little work that looked about the longer outcomes of the training. So it was really about what do people think about this training immediately after they've had it? You know, what were their first impressions? Did they enjoy it? Did they learn things? And actually, we were more interested in some of that longer term outputs. So in summary, our review of the evidence demonstrated that learning disability training can lead to positive outcomes in terms of increased knowledge, confidence, more positive attitudes. There was some evidence to suggest that training can lead to changes in practice, and they gave some examples of this, but very few looked at this a bit further down the line, so a few months later, and then none of them at all explored any impact on the patient outcomes, which again is what this should all be about, really. But despite the limitations in the evidence base, we were able to make some key recommendations just from that first stage of the work about effective learning disability training. So, for example, it was very clear from what we were finding that training should be designed and developed with people with learning disabilities and with the staff who would be receiving it. If we move on to the next slide, it's about our second stage of work, which was staff surveys. We wrote 2 of these. The first one went out to staff who were involved in delivering the learning disability awareness training, and that had questions in about things like the content and the format of the training and how often it was done. The second survey was open to any staff working in the South NHS trusts, so it doesn't matter what their roles were, they were welcome to fill it in. And that was more asking for their experiences, if they'd been offered any training, and if they'd done it, what they thought of it. When we analysed the responses, we broke it down into staff that were working in Tier 1 and Tier 2 roles as defined in the core capability framework. So that's why in the brackets, there's 2 sets of numbers there. The first finding was that less than 1/3 of the staff had done any training at all on this, but nearly everybody that hadn't said they'd really like to do the training, which we thought was quite positive. And then other positive findings were that nearly everybody that had done the training said they found it useful. So that's over 90% in both groups there. So it really was nearly everybody. And most people said that they'd learnt stuff, it had increased their knowledge. Fewer staff said it had made a difference to their practice though, although I would think that those numbers there, 69% and 76%, are still quite promising, but we can see that slight decrease from usefulness to knowledge down to actually putting things into practice. When people with learning disabilities have been involved in the training, respondents were overwhelmingly positive about their input, and most respondents thought they should be involved if they hadn't been involved, which didn't really surprise us, to be fair. So we did these surveys with everybody, but we wanted to talk to a smaller group of people to find out a bit more detail about their experiences. So I'm going to hand over to Rachel now, who'll take you through a few slides about the interviews we did with hospital staff.
Thank you, everyone. Thank you, Anna, sorry. These were delayed and took place online due to COVID. So unfortunately, we couldn't do it face to face. We had to do it online. All the interviews were done by an NDTi staff member and a core researcher with lived experience. So we had an NDTi staff member and a core researcher planning questions and doing the interviews and everything. We interviewed 3 trainees and 3 trainers, and 7 trainees, a total of 10 NHS staff covering 8 hospitals. We didn't want to do it just in one hospital. We wanted to find out some more information from other hospitals as well. We found 5 key things that are important for good training, which I will tell you all about now. Next slide. They're interactive and fun. So people said good training had a mix of activities and was interactive. So for example, there were people meeting and talking to people with a learning disability, helped understanding and confidence. So some said they would have liked a longer course with more time for this, and people learned a lot from the others on the training course. So it was good that they all learned from each other as well. Next slide. Oh,
I think you've just covered that bit. Sorry, Daniel, I think these slides come up in chunks. There you go, Rachel.
Thank you. Real life stories. So hearing about people's real life experiences is important. So this can be through case studies, videos, or in person. So people can just have a look at the videos and case studies to learn more. It is good to hear examples of when things have gone well, not just when things have gone wrong. People learn how to get it right. So good examples, videos can help. So it's always good to have videos to help as well and learn from good things as well. For the co-trainers with lived experiences, sometimes people did more than tell their stories. They delivered the training. This is what one trainer told us. Having patient stories and a co-trainer with a learning disability helps change attitudes more than anything else. Next slide. Skills and ongoing support. So trainers need to be knowledgeable, committed, enthusiastic. So it's important they're not just on the phones, like emailing, texting, or doing any other things like going on tablets. It's important that they're committed and enthusiastic. They've got to be totally committed to it. People wanted ongoing support and advice. So this was usually found from a learning disability liaison nurse. So for example, that was looking after more than one hospital. She was your go-to-go person. She did all this training. So that's lovely that she was able to support the staff doing the training, because what was important that we found was that they needed ongoing support and advice after the training. The impact of learning disability training, everyone was positive about the training and gave examples of what they had learned and what they had done differently. So this is really good, and staff need to think about what individuals like and don't like when thinking of how to support them and make a reasonable adjustment. So it's important to get to know the individuals before making any judgments. I'll hand over back to Anna.
Thank you, Rachel. So the next stage of the work was something called a Delphi study or survey. So this is an iterative methodology for trying to reach agreement on a given topic from a panel of experts. So in this piece of work, we had 57 experts from about 10 countries contributing. They came from mainstream primary healthcare, acute hospital settings, and some learning disability health professionals and academics as well. So in a Delphi study, what we do is ask people to what extent they agree with a list of statements. So the statements we sent them were identified from the work we've done so far. So the literature search, the surveys and the interviews, the findings we'd got from those. So most of this list of items related to things like the aims and the design and how the training should be delivered. But we also included about 30 items which are about systems related indicators. So things like the resources people need and what sort of outcomes they might see. We thought that it was really important to include these sorts of items, because if we only focus on the content of the training, we're not really understanding the context in which it's being delivered and the mechanisms that might help or hinder people from putting their training into practice. So one example of an item in the survey is something like the learning disability awareness training should be designed in partnership with people with learning disability. And then in round one, panel members were asked to rate that on a 5-point scale. So that went from strongly disagree to strongly agree, with the steps in between. We then looked at their answers, and in round two, any of the items where there wasn't really strong agreement between everybody, we asked them to score them again, and we added in some new items based on their feedback. What we found overall, that amongst that panel of experts, there was quite strong agreement about the kind of aims, the design and the content of a learning disability awareness training programme. But there was more of a mixed response around the sort of delivery and delivery mode. So whether it was best face-to-face or online, for example. We also, through this, identified 7 main barriers which could obstruct the implementation of the training, including things like lack of resources, technology, and lack of clear policy and guidance. When designing, amongst all the stages of the work we've done, it was really obvious to us that good learning disability awareness training involves people with lived experiences. I'm sure none of you are surprised to hear that Daniel was saying it's a shame Ronnie isn't here today because of what he brings and adds to it. But we also heard about some things that can make it difficult to involve experts by experience, like paying for their time if they're on benefits. So we thought it was kind of important to not just kind of glibly say everybody should involve people with lived experience, but to actually look at in a bit more depth at the challenges of that and what you need to do to make that work well. So this is one of the extra pieces of work we did. And Rachel's going to tell you about that because she was involved in that piece.
Thank you, Anna. So the first thing we did as expert by experience work was we did interviews and focus groups with people who had been involved in training. So this included self-advocates, there was 3 of them, family carers, there was 3, and NHS practitioners, there was 4, which was really good. So it was really good to have a mixture. We found 4 key things that were important for good involvement of expert by experience in training. So the first thing that we found was, next slide, sorry. The first thing we found was working together as a team, which is important. Teamwork means being involved from the start and seen as equal. So they've got to be involved from the start to the end, and they've all got to be treated and seen as equals. Good teams understand each other's ability. And what was important as well was that they got to know each other, because unless you get to know each other, you will not be able to know people's skills and how to help each other and work as a team. So that was really important. And everyone should have a say, really, which is really important. So, but just to add to those 2 things with that, which I like to just raise, is that with everybody having a say and getting to know each other, that's so they can work as a team, is important then that they can speak to each other. That's so then they're not just relying on one person. So for example, the bosses or learning disability liaison nurses, it's important they have more than one person to talk to. Next slide, please. Building confidence and offering support. People got more confident over time, and budding and mentoring helps, and don't make assumptions about the support people needed. So with that, they found out what they needed in order to feel prepared and ready to deliver the training. And the other thing was that when people got more confident over time, as they delivered the training more often, the more they did it, the more confident they got. Next slide, please. Respecting and valuing people. Everybody should be respected, which is important. Everybody should be treated the same, doesn't matter on your needs. The payment is part of feeling valued, which is really good because it shows that you're getting that reward, which is the same as when your child getting pocket money. People should only share what they are comfortable with. So with that, it's important that it gets confidential as well. So it's private and confidential, gets said in that meeting or in that room at the time. Next one, please. Enjoyment and having fun. Everyone wanted to raise awareness and make the training fun, which is really important. It's important that we have good times. Informal chats during the training are enjoyable and useful. So having face-to-face training, tea and coffee breaks are really important, because it's good to be focusing on the training, don't get me wrong, but it's also important to have tea and breaks, people have said. That's so then they can have a chat at tea and lunchtime. Next slide, please. We have made a toolkit of what to do and what not to do before, during and after the training. Some examples are: do build in time for longer meetings. There's an easy read paperwork, etc. for that you could read. Do have a co-trainer to share the load and provide support. Ensure that people have the opportunity to stop, pause and debrief, and have regular team meetups, which is really good, because it's important that will come under people having a say, and it will be important then to remind people in the training what needs to be done and what needs to not be done. And there are loads more examples and advice in the full support. There is a link in the toolkit and the report at the end of the slides. Please read and share it. with your colleagues and networks, because it's important. The more people that know about this, as you can see today, there's more than 40 of us today. The more people that know about it, the better it becomes. So please share it with your colleagues and do networking. I'm going to hand over now to Callie now.
Thank you. If I could have my lovely, thank you. I'm going to talk to you about an additional piece of work that we hadn't planned initially when we devised the project plan, and it's a reality check workshop. The reason that we held this workshop, which included practitioners, senior managers, and a range of people working in trusts, was we first of all recognised the multiple demands and the huge pressures that trusts are under, particularly in a post-COVID environment, but also because as a project team, when we came together and analysed some of our findings, we felt quite passionately that training is only likely to make a sustainable, systemic difference to people if it's delivered in a supportive environment in which staff feel enabled to improve practice. Training in and of itself is not the magic bullet. We discussed previous work around quality improvement in the NHS and some of the success factors and barriers to change. I think we're all very familiar with some of the barriers to change around people not feeling that they've got enough headspace or motivation or even set of skills to do this. But some of the success factors are clearly around leadership, around creating a culture that supports change, a culture where evidence is collected to demonstrate change, and generally just generating a very supportive environment to improve practice. We also recognised that, that the change needed to happen at 3 different levels if it was going to be successful. And as a result of that, we looked at 3 different levels where change needed to take place and what would support it. Next slide, please. At the first level that was discussed was at the team and departmental level. And I feel very strongly that as I walk through the door with my son to receive healthcare, actually this is where it's so important that it makes a difference. Some of the factors that we discussed were the need to follow up the training and ensure that staff are using what they've learned, a point that is reiterated again by Anna. It was important to make sure that learning from training is built into supervision sessions and team meetings agendas, and it really provides practitioners with an opportunity for reflective practice on what it is that they're doing. And also to provide peer support opportunities for staff to share some of their experiences and problem solve together. It's very interesting. My daughter is a nurse, and I'm always learning really from her experience of what's actually happening on the ground. She is involved in running a very busy ENT clinic. And what they did at a staff and team level was actually explore some of the things that they needed to do to change the practice, the way that they delivered and improve their clinics. So it resulted in better outcomes for the people with learning disabilities and their families who came through the door. But it also enabled them, through talking about it and reflecting on change, to do their job better. And to improve some of the performance indicators in their particular area. The next slide, please. Clearly, trust level is an incredibly important area, and this needs to ensure that there's senior sign-up and leadership to support decision-making and to tackle some of the system blockages that might be involved, and to make sure that the message is communicated with staff that this is important. It's important as well to build clinical involvement and buy-in through reinforcing some of the connections between making reasonable adjustments and improving health outcomes for all patients. it's important that learning disability is woven throughout the Trust's activities, that the connections are made around the work that the Trust might be doing around equality, supporting carers, safeguarding, and also looking at data systems. In particular, I think it was really interesting in the Trust that my daughter works at. The work that they did at their departmental level came about because she was offered a Chief Nursing Junior Fellowship, which works both as a retention model for staff, but also as an integral part of the service development and improvement in the Trust. And it was this opportunity promoted at a senior level, woven through the Trust, that enabled them really to make a difference at their department level. Finally, next. Thank you. It's really important that this local work is supported by national, regional initiatives, including at the integrated care systems level. It's really important, I think, that we continue to make available, encourage participation in any national benchmarking programs there are in order to drive up local quality improvements. The Health Education England has a really important role in developing their role in following up new legal requirements for training on learning disabilities and autism to ensure that trusts in particular are meeting their care quality standards. This includes, I think, encouraging reporting the difference that training is making to outcomes and experience. It's not just about crunching numbers, but it's actually following through and finding out what difference that it is make, how a trust's actually going to monitor the impact of the training. Obviously, the Care Quality Commission plays a very useful role in highlighting examples of interesting practice that can be shared across trusts, both in terms of overview and thematic reports that they produce. And finally, national and regional learning disability programmes can encourage the sharing of learning across trusts. Often people just don't feel confident that they have the skills or the knowledge to make the difference. So it's important that all of these three levels actually are interwoven together, because it's only when we've got the national, the trust level, that we're going to see the difference at a departmental level that really makes a difference to people's experience of visiting the trust. Next slide, please.
Thank you, Kelly. So as of today, we have now published all our reports relating to this work. So hot off the press literally this morning is a final overarching report, which talks through, a bit like we've done today, a summary of all the stages of the work and signposts the different outputs from the different stages. And there's an easy read version of that. There's an easy read version for everything we've done throughout this. So what I'm going to do now is just in these last few slides run through a few summary bits where we pulled together some of the overarching findings. And as with the other bits of this work, just to note, we're only giving you a few examples from the things in the report because there'd be far too much to talk you through everything. So don't think this is comprehensive, it's just some of the bits we cover. So in terms of the content and style, our data does suggest the training should be face-to-face, although I think it is important to note that some of the data we collected was either pre-COVID or early days of that, and I do think that's changed how we work online. But we did find that people valued it being interactive and in small enough groups to have the approach. And we're also aware, of course, as Rachel spoke about, how much people got from those informal conversations with people with lived experience. And that's only going to happen if it's face-to-face, just those casual conversations and chats with them as a person, rather than the delivering a piece of training, seems to be really valuable. The training needs to be long enough for them to have those times and discussions and questions as well. And we want the inclusion of real life stories as well as examples of good practice from the hospital. People found it quite useful to hear about things that had already happened and to know that these are realistic and things they could do as well. And it's very important to share the positive stories of impact. The training definitely needs to have a practical focus and go beyond rules and policies. So whilst people might need to know the 5 principles of the Mental Capacity Act, they really need to know how they go about putting it in practice and doing a capacity assessment with someone and what it means when they're trying to take a decision about someone's treatment, rather than just the sort of technical legal aspects of it. People also felt that it was really useful for them to have access to resources and signposting about what they could use, where they could go for further help. We made some recommendations about the content, about 5 broad areas around medical conditions, communication, pain, ethical standards, information and resources. And we've also made some suggestions for core topics for inclusion, which were things like diagnostic overshadowing, nutrition and hydration, and epilepsy. Whilst we think that the training probably needs to be generic enough to allow training from mixed professional groups, it also may need to be adapted for different staff groups within a hospital, or alternatively, perhaps more bespoke department or role-specific training could be offered. We did find that some of the nurses in hospitals were saying that specific departments had certain issues they needed addressing. They found that quite a useful additional extra. Next slide, please. Again, everything we did gave a clear and consistent message about the need to involve experts by experience in the training and the benefits that has. Rachel's already talked you through about the best way we found to support experts by experience, and I would really recommend the toolkit she's talked about. I'm sure some of the things in there are very obvious, but sometimes we find it's quite necessary to state the obvious, and hopefully there's still some good ideas and top tips in there for people. So we have made some overall recommendations, and we think that people with lived experience should be involved right from the beginning, so in the design as well as the delivery ideally. And when we're talking about experts by experience, we're talking about people with learning disabilities themselves, but also their family carers. They're also got their own expertise. We think it's important to involve people with higher levels of support need who use different forms of communication, perhaps. That might be in person. They may be able to come in and deliver part of the training or be part of the session, but it also could be through the use of videos or something. Staff undertaking the training want that opportunity to interact naturally, as we've said, and that will only come through the face-to-face things, really. Although the message was very clear that we want experts by experience involved in the training, we did identify some challenges. So we know that sometimes hospitals might find it hard to find a budget to pay for involvement, or there's practical difficulties of paying people on benefits, etc. But we have put together some advice about some of that. We're also aware from our work on the Oliver McGann mandatory training particularly, there's a need for sufficient training and support if people with lived experience are going to be delivering training. If they're going to do more than simply just share their own stories, they need to have been supported to get the skills around facilitation, keeping things on time, responding to questions, etc. So lots to do there. And then the final slide. This is about, if I can move on to the next slide. Yeah, thank you. After training, as Callie said really clearly, it's not just enough to deliver the training. Trusts need resources and a system where change can thrive. So again, this is very similar to the bits that Callie ran you through, but this idea of backing up training with on-the-job support. So things like someone being helped to do a mental capacity assessment or DOLS assessment after they've had the training around it. Peer support groups and reflective learning opportunities. People said that it was useful to be able to have somewhere to bring case discussions, case study discussions, bring real life problems, get some advice from colleagues. That advice from colleagues might come through learning disability champions. We did find that when people had done some of the training, it really, in some people, sparked a real passion to do more and learn more and have a bigger role. And Rachel already talked about a heavy reliance on learning disability liaison nurses, and maybe champions is a way to have a greater coverage and support there. People wanted resources to take away, they wanted to be signposted to things, and there's so much out there already in terms of easy read information, etc. If we can direct people to where they can just print something off, it's great to have those things used in their practice. Regular updates are important, but we're aware it's probably unrealistic to say that people are going to have this training really frequently. But we thought that there could be ways to explore just kind of reminding people about it. So that might be by sharing a new resource, or there might be a new video out that's useful. And just if that could be shared with people that have done the training, and just a little bit of that, don't forget about this training you did, and have you thought about this recently? And we also know it's important that hospitals look at the impact of the training. We've said several times already, at the end of the day, this is about people getting better care, and really ultimately it's about people, less preventable deaths happening to people with learning disabilities. So we need to sort of be able to monitor that. So that's us done. I'm going to hand over to Rachel now, who's going to tell you about the next stage where you come in.
Thank you, Anna. So the next stage for everybody is that now we are handing over to you. You're going to be put into breakout rooms, and we would like you to discuss a few questions. The first one is, what do you think about what we've found? How does this link with what is happening in this area? What do you and your colleagues, your organisations need in order to ensure this training leads to positive change? And the third one is, what next? So there is someone facilitating and taking notes in each breakout room, and please agree a couple of key points to feedback from each discussion. So remember, that bit comes under teamwork.
Welcome back from the group work. Let me just check everybody's back in the room. It looks like all the rooms have closed now. Yes, that looks like a good sign that we've got everybody back. We've got some feedback to do then. So who was in group one? Can everybody see the Menti? I've the Menti screen. I can see some nods. That's a good sign. Who was in group one? Oh, was that Michael? Was that your group?
I think it was. Yeah.
Have you got a couple of things to feedback, particularly from these questions?
Yeah. Well, actually, the work, pretty amazing work, and great ideas, great initiative, and I guess in terms of challenges, it's focusing on the logistics of how you can really embed this type of work in a true co-produced way. So it's not a tick box exercise, but also I guess like properly structured and funded. So if you have people who are experts by experience, who are invested in this co-produced training, there is just the cost of making sure that those people are properly remunerated, and some concerns perhaps with some people about how that might impact upon their benefits, etc. Just working through those logistics. But it wouldn't just be simply a matter of people being paid for being in attendance and participating in a training session. People need perhaps lots of preparation in advance to ensure they're fully equipped and fully confident with the material, and making sure that material is truly accessible to those individuals. So lots of challenges, and perhaps in terms of all of those logistics and like funding streams, and I guess I was wondering, so that this was a wonder from me about these sort of conversations and connections with hospital settings, is the question of reasonable adjustments. So there are potentially opportunities here for a wider national sharing of what reasonable adjustments like work for different people, because everybody's different. Everybody has different anxieties and challenges when they're in clinical environments. But is there a mechanism at the minute, or could there be a mechanism within this structure for ensuring there's a wider sharing of really good ideas, really creative ideas around reasonable adjustments? Was there anything else, anybody in the group?
Okay, well, I think those are both really pertinent. How we, that infrastructure for meaningful involvement of experts by experience, and how they're recompensed, and frameworks for making reasonable adjustments is two really pertinent questions for us to kind of ponder. Room 2, I think that was Anna, Jennifer, and Lisa. Have you got any feedback for us?
Oh, sorry, which?
I was going to say, I thought I was room 3. Sorry, is it different Anna? Or...
It's a different Anna. Sorry, Anna.
That's right. I keep quiet.
Happy to feedback, Daniel. So I think there was sort of a mixed experience in our small group around sort of knowledge and awareness of the Oliver McGowan mandatory training and how to access that. So we did have a sort of a question for the NDTi team, whether you can share any kind of central hub where people who are here today can go out and find out more about training, how they can get signed up for that, or advice around where they get that information, who should they speak to within their trusts about that. So that there may be something for the chat there. I think one person had undertaken the training themselves and found, as the sort of evaluation showed, that the importance of the role of expert by experience in that came across really strongly. In terms of kind of maintaining a focus on learning after the training, it was emphasised that peer support and reflections are part of the Nursing Council qualifications and maintenance of qualifications, and that those are undertaken over a 3-year period. So actually, is there a way to look at different allied health professionals and their sort of registration bodies to see how those reflective processes could be built into some of the requirements that professionals already have? Clear that having a learning disability specialist team within the trust to liaise with is really helpful, both in terms of promoting the training and to actually be able to problem solve around reasonable adjustments and developing strategies actually of how to make things more accessible. What else? There was a couple of other important points. One of the things that came up was around disclosure, actually. You know, would people always be able to identify if someone has a learning disability, are autistic? And so how might we also be thinking, as a very standard reasonable adjustment, identifying whether people have additional needs, and having a very validating and affirmative response to people if they are disclosing that, and a sort of instantaneous really follow-up around adjustments that people might need. Yeah, so
I'm gonna cut you off there, Lisa.
Please do cut me off.
Aware of time.
Go on, Daniel.
Well, yeah, I'm sorry, I'm working.
So if I can hand over to Anna. You were in group 3, weren't you?
No, I thought I was. Thank you, Daniel. Yeah, we had an interesting discussion. I've got a few random notes. I'm afraid I didn't manage to coordinate using Menti as well. It was a step too far with everything. But I've got some notes down on paper. There was definite strong agreement about the culture of the NHS being a key issue, and there were concerns about this idea that the Oliver McGowan training will be a bit of a tick box exercise. I think someone's already used that phrase, and really wanting to make sure that it isn't, and about how that can be followed up and that things put into practice and that assessed. There was an interesting discussion around the idea of, we've been thinking about what wider work is needed to get the training put into practice. But I must admit, I hadn't linked this with coming at it from very much the other side about training and education to people with learning disabilities about their own health and the steps they take to it, which is stuff I've been involved with previously. But I hadn't really thought about actually dovetailing these two and thinking about coming at it from both ends, that we try to improve, you know, literally the reception people will get, the service and support they will get if they come into contact with health services, but also their own engagement in it. So I thought that was something worth returning to. And then we did move on to think a bit about the what next, and talked about the value of working with services to look at the outcomes. And I was saying within that I think it was our Delphi study in particular, we have suggested sort of the signs of change you might expect to see in a hospital trust in a year, 5 years and 10 years. And it'd be lovely to do a piece of work around really sort of monitoring some of that and seeing if those things can demonstrate it's improved if you put the training into, you know, if you deliver the training to everybody, but then also have sort of maybe an approach or a real action plan about how you'd maximize that and make it benefit. You know, something we'd love to be involved in, but obviously would need funding and properly thinking out, etc. And then also the thought about taking it wider, which I guess is where Oliver McGowan comes in, because it's health and social care, about actually the need to not just look at you know, very much this work, the remit of this work was hospitals and NHS trusts, but therefore thinking about the community as well. And obviously there's that route for people that so many people end up in hospital when, if their diabetes or epilepsy was well managed in primary care, you might not get those things. So thinking, I guess, some of it about joining things up and thinking about it from both ends. Thanks.
Excellent. Thanks, Hannah. Room 4, that was Callie, Emily, Ishbel, Jacqueline, Linda and Rachel.
All right, well, thank you. A bit like Anna, we didn't manage to do the board either, but we did have a very lively discussion, and we were an interesting mixed group because we had some people who were employed as specialists, you know, learning disability workers in different environments, but also people who were doing different roles. So it was just very interesting to have those different perspectives. In terms of just 2 points that we've been asked for, I think there was a consensus that there's some real value in the resource that Rachel talked about, the toolkit in particular. People were very keen and enthusiastic about ensuring that experts by experience were involved throughout the entire process, and but also recognise some of the barriers and difficulties that you know, happen sometimes to really stand in the way of that happening. So people were very positive about how helpful that might be, and there was also some comments about how not just COVID, though it's made a massive impact, the involvement of people with learning disabilities and people with lived experience has in some ways gone backwards. So it's really important that we begin to sort of build that back up again and make sure that people are included in the entire process around developing and monitoring and delivering training. In terms of issues that might be problematic and hinder development, I think there seemed to be a consensus around the issue around engagement. Wherever people were working, there were real concerns about, you know, whether or not we could engage consultants with this, how could we involve people who are non-clinical staff. So the issue about engagement ranged across the environment. In particular, one person talked about how with the Oliver McGowan training going sort of live in terms of being a mandatory requirement, this they could see would cause problems for the workforce metrics that the Care Quality Commission was going to be doing. If you wanted to make a start now, actually, if you don't dovetail and compliant with the Oliver McGowan work, then that's going to be quite difficult to engage people with as well. And somebody make a really important point, really, that linked up with what Anna was saying about this is generic training, and our brief was definitely about working in hospital trusts, but that we do need to make sure there's opportunities for context-specific training and reflection, because obviously people do have different roles and jobs within a trust, which is a very complex organisation. So I think those were some of the main points, but a really interesting discussion and lovely to have a mixed group talking together that might not normally have that opportunity, a range of skills.
Thanks, Kelly. And then the final group was Claire, George and one other guest.
Yes, so it was Claire and Ricky and myself, I'll give you a flavour because there was far more than this. So in terms of it was welcomed, I think that was the first thing, is that to have some practical, this is what works, was to be applauded. And I think that's something that we all agreed on. But then how does that link in our area? We're saying it's very much around waiting for the things that allow us to enforce it. So we talked about the code of practice, which hasn't been published yet, that's on the back of the Act for mandatory training, would be really helpful. And then that led us on to thinking about, well, specifically, do we have enough experts by experience, and do they represent the majority of the kind of people that we'd be supporting in a health setting? So we were talking about minority group experts by experience, and the fact that one of our colleagues that had experienced the Oliver McGowan mandatory training trial had only observed one colleague from a different minority group. So it was just that, is it representative and does it address everyone's cultural needs? We talked a little bit about staff coming into the country. We have a lot of overseas staff, and how are we making sure that that they equally are going to be getting this kind of fundamental training, because we know that we're using that as a nation at the moment. We talked a little bit about human factors, and actually, if you turned it on its head, rather than giving training to people now, why is it that we don't do it as people come into the profession? And we actually made mention to the Common Core curricula that didn't appear, that was in the response from the government, and that was part of the Oliver McGowan training, and we wondered where that was from. And then in terms of next, there was a mention about kind of how do we record, but not just completing the training or having an experience with experts by experience, but also the impact, because we've acknowledged that generally something like Oliver McGowan comes out, or mandatory training, and then it just has bolt-ons over the years, as opposed to saying, well, this works, carry on doing it. That doesn't work, let's not do that. So they're the themes that came across from the group. It was really rich and a useful conversation.
That's great. That's great. I mean, there's two things that I particularly tuned into that seem to cut across a number of the group work, which was one about how regulators influence this process and how they could influence in relation to what goes on within the organisations, but also what goes on for individuals and how and part of their revalidation process, but also about, well, how are we going to know whether any of this really works, and what the impact of the mandatory learning disability and autism training might be in the future, either from a longitudinal perspective, but also from that that impact perspective as well. Really, really interesting feedback. Now, I'm aware that there's we've got a couple of minutes left. Michael, are there any particular pertinent questions that we need to cover that haven't been so far?
I think that there's a couple of points in terms of like research, and one point from Linda in relation to an evaluation of what's actually covered in initial training for nurses and medics. So then, this type of initiative would be building upon that, but whether there's any evaluations of initial training for different types of professions. And also
a fair amount of research out there around that, and we're hopefully going to do something similar to that locally at some point soon. So,
and a couple points. Well, they were from me anyway. One was around, is there a difference when you have a learning disability liaison nurse based in the hospital or not? Because if there is, then there's an argument there to increase the numbers. And then just focusing on people with profound and multiple learning disabilities. In my experience, often when they are admitted to hospital, expectations of their survival, for example, is quite low. So making sure that there's representation for that group of individuals.
Excellent. Thank you, Michael. I'm noting that it's just clicked through to 2 o'clock, so I'm just going to move that Menti across. We will make sure these resources are made available, as well as the recordings, very soon. All of Anna's slides and resources will be made available, and all of the details should be on your screen right now. And it's just really to say thank you so much for being with us this afternoon. Thanks for contributing and for registering. There will be an evaluation form that will be hitting your mailbox in about 40 seconds ago. If you were able to do that, to have a look at that, that would be really useful. In there, we're asking a question particularly about along with how you found today, about whether you would be interested in getting together for a face-to-face meeting again next year. And if you've got any particular interests or topics that you think we need to cover in something like this, or want to get more involved in the steering group, then please make contact with us, either via email or via the website, or via the Twitter handle, or via the Facebook page. And if we don't see you before, then have a wonderful Christmas, and we'll catch up with you in 2023.